Again. A few minutes back, we talked about the presentation of a patient with SLE, how to present a long case of SLE. Now let's go through the question and answer that you might face after presenting your case. Okay, so I have said that my provisional diagnosis is SLE with lupus nephritis, and my differential diagnosis were rheumatoid arthritis and mixed connective tissue disease. So first question might be that how you have concluded that this is a case of SLE. What are the findings that support your diagnosis? First of all, you can say that this is a young woman, classic case for SLE, and then you say the presentation. The patient has classic presentation, which are the patient has malar rash, oral ulcer, joint pain, which is non-deforming arthritis, and you have the features suggestive of lupus nephritis. So those are the classic features that suggest that this patient is probably suffering from SLE. Then you might be asked that what are the investigations would you like to do, and tell me the expected findings. So the investigations are mainly due to diagnosis, and you can also say there are some investigations that not only diagnose the case, but we can also say we can also see the activity of the disease. For example, if you do the complete blood count with peripheral blood film, you will get a feature of diagnosis and also some features that support activity of the disease. So for diagnosis, you see in CBC you will get anemia. There can be an autoimmune hemolytic anemia, which supports the diagnosis. But if you see a lymphopenia, that suggests that the disease is active. Anemia supports the diagnosis. Lymphopenia says that the disease is active. Then ESR also corresponds with disease activity. Whenever the disease activity is high, the ESR will also be very high. And you might also get thrombocytopenia and leukopenia. The CRP is classically normal in SLE. So remember those conditions who have normal CRP but raised ESR. So you have conditions such as systemic sclerosis, where the ESR is high but the CRP is normal. SLE is another condition where the ESR is high but the CRP is normal. And you can also mention the multiple myeloma, ulcerative colitis, where the ESR is high but the CRP is normal. High ESR but normal CRP. In a patient with SLE, if you get a high CRP level, that means the patient is probably suffering from infection. He or she has some sort of infection, or maybe in serositis. Then for confirmation of diagnosis of SLE, you might have to do the antibodies. The classic antibodies that you start with is ANA, and then you go to the specific ones, which are anti-dsDNA and anti-Smith. Remember, for disease activity, you must have to repeat the anti-dsDNA, because anti-dsDNA is specific and it corresponds with disease activity. So very important, anti-dsDNA. In this patient, we have to check for lupus nephritis, so we have to do the urine RE, you have to do the 24-hour urinary total protein, and you have to do the renal function test. Then we might also check the complement levels, because whenever you have a low complement level, this suggests the patient is having an active SLE. So we have found few criteria that suggest active SLE. This is a question in FCPS as well. You have in CBC, you have lymphopenia, active SLE, high ESR, active SLE. Then in patients with SLE, if you find that the patient's dsDNA titer is very high, active SLE. Complement levels low, active SLE. So patients with lymphopenia, high ESR, high dsDNA titer, and then the low complement levels, all of those suggest that the patient is having an active disease.